Good afternoon and welcome to the second plenary session. The speaker is Dr. Mark Walker, probably has already been introduced. He's a professor and honorary consultant physician at Newcastle University, UK, Associate Dean for Clinical Research and Support, Director of Newcastle NIHR Research Center, past chair of EASD Scientific Program, and his research interest is on genetic basis of type 2 diabetes. And he's going to talk to us on inflammation to insulin resistance and pathogenesis of diabetes, its implication in clinical care. Dr. Marco.
So thank you very much. And as I said yesterday, it's a real pleasure to be invited to the symposium. I've been very impressed by the organisation and the stimulating topics. And I'd like to congratulate the organising committee and the faculty for putting together a great programme. So while I've been here, I've learnt a little bit of diabetes, but I've learnt a lot more about the geography of India. So every time I get a card, I look at it and I think, where's that? And so I get a little geography lesson. So I'm going to tell you a little bit about where I'm from. Some of you will know because you've trained in Newcastle, but I'm from Newcastle upon Tyne. And where is that? Well, this is the UK, and most of you will be familiar with London. Many of you will have passed through or on your way to the States, or actually that's been your final destination. Up here is Edinburgh and Scotland, and that's the border there. And this is Newcastle, so we're kind of considered up north. I understand in India you have a north and a south, or we have the same, and we're the northern end. And you can see that we're fairly close to Scotland, but actually that's not always been the case, because it's about 2,000 years ago, we were part of the Roman Empire, and the Roman Empire extended to this wall here called Hadrian's Wall, and actually it passed through Newcastle. So Newcastle was literally on the edge of the Roman Empire, and so if you went north, that was kind of heathen territory when men wore dresses, and they were kind of an unruly lot. But further south, this was the Roman Empire. And I've got to say, where I live, I'm actually north of the wall, and so I'm still part of the unruly lot. And just so this wall still exists, this is Hadrian's Wall. You can see it moves along here, and you can see it going into the distance. And so you can imagine an Italian guy, Roman, in Rome, enjoying the sunshine, suddenly being told he's going to Hadrian's Wall to the edge to protect the empire and ending up here. And there's not much to do there, but you say this is the Roman side, and this was the beyond. What about Newcastle today? This is a picture of Newcastle, and this is one of the things it's famous for is its bridges. And when we say Newcastle upon Tyne, this is the River Tyne. This is Newcastle, this is Gateshead, but essentially the one metropolis. And the other thing that we talk about a lot in Newcastle, so I understand that cricket is a real passion here. Not really in Newcastle, but what we are interested in is football. And so this is St James's Park, where Newcastle United plays. And my seat is just about there. I'm not sure whether I was there on that day, but that's where I sit. Anyway, so that's where I'm from. So moving on to the talk, the WHO classification, type 1, type 2 diabetes, we're all fairly familiar with this. But actually in the definition of type 2 diabetes, it says that there's both decreased insulin secretion and insulin resistance. Okay, so insulin resistance is something that is recognized, but it kind of gives the impression it's an all or none phenomenon, but we know that this is not the case. So here's a plot of insulin secretion and against insulin sensitivity. So people are very insulin sensitive at this end, and as you move down here you become more insulin resistant. And even if you take non-diabetic people, there'll be some people who be insulin sensitive, but as they move down and become more insulin resistant, they secrete more insulin to maintain normal glucose levels. And the point of showing you this is the fact that if you draw a line here, These groups, whether you're non-diabetic, impaired glucose tolerance or diabetic, they've got the same level of insulin resistance. It's just that they secrete different levels of insulin, and the diabetics are short of insulin. So it's not an all or none phenomenon. There's a continuum of insulin resistance in the general population, and certainly the diabetics tend to be at this end. And what about the tissue site? And this is a summary slide from Jerry Shulman's work, where they look at muscle glucose uptake. And they've shown that muscle, skeletal muscle, is a major site of insulin action and glucose disposal. And they've looked at glycogen synthesis here, and this is a measure of glucose uptake. And they've measured it here in controls, in lean controls, and they have good uptake of uptake and glycogen storage. Obese subjects, both are decreased. Insulin-resistant offspring of diabetics, both decreased. And type 2 diabetics decreased. Interestingly, type 1s can also be insulin-resistant at times if they're obese or if they run hyperglycemia. But the key feature is that the point I want to make here is that insulin resistance in skeletal muscle is a major problem for our type 2 diabetic and generally obese patients. And this is a slide that used to go around when I was a young trainee, and that tells you how long ago it was, about 20 years ago. But basically, this was the idea of insulin action. So it says insulin combines with the receptor, then there's a black box, something happens, and then there's the effects. And this guy says, after years of intensive research, we finally got a clear picture of insulin action, a long way from the black box concept. So there was a lot of ignorance around what happened. This is what happens. This is what's in the black box. It's terribly complicated. Insulin receptor here. Don't worry, I'm not going to go through all of this. Okay, so you can just relax around this. But to make the point that it activates IRS1, there's phosphorylation through PI3 kinase, activation of AKT, and then a number of effects. The point I want to make from this slide, despite all this fantastic work, people have spent their lives looking at this pathway, there's no single point of abnormality in type 2 diabetes that causes insulin resistance. We know that some variation in IRS1 can contribute, but there's no single abnormality or blockage. So a lot of interesting work, but it's not really given us the answer of the insulin resistance in type 2 diabetes. So what I'm going to talk about over the next few minutes is these are the points. I'm going to talk about obesity and inflammation. I'm then going to talk about skeletal muscle and inflammation. And then I'm going to finish up with what are the possible clinical consequences, and in particular about clinical practice. So the first part, obesity. You'll have seen this slide in various guises over the last few days, and this is out of date, so it's 2006, it's from the IDF, but this we're trying to project the prevalence of diabetes around the world. And just to focus in the UK and Europe, they predicted that by 2025, the prevalence of diabetes has gone up 21%. And we think, well, that's a lot, but it's nothing compared to what's going to happen elsewhere, that is predicted to happen elsewhere. So if you look at the Middle East, it's expected to go up by 81%. India and Asia, 73%, and you guys are fully aware of this. You don't need to tell you this. You see it every day, and other parts of the world. So we're kind of small beer in Europe. It's elsewhere that the kind of so-called epidemic is happening. And we know that urbanization, increased obesity are the key drivers, and again, that's well known. So what is it about obesity, insulin resistance, and inflammation? And I've got to say that this is work in progress. So if you're wanting the final answer, I'm not going to be able to give it to you, but I can tell you where we're up to and what the thinking is. What seems to happen, this is in the lean state. We have adipocytes, and they're fairly healthy adipocytes. They store fast, they've got the odd macrophage, and they're behaving themselves. As we store more and more fat, the fat cells there's a limit to the number of fat cells that are available, so they start to hypertrophy and they become enlarged. And this seems to be a trigger that sets off the inflammatory process. Okay? And I'll say a little bit more about that, but the macrophages change, there are other metabolic changes, but it's this change with obesity to the hypertrophied fat cell that seems to be the problem. And I seem to have a problem. There we go. Right. So taking this a little bit further, that as the fat cell enlarges and becomes hypertrophied, this seems to trigger a series of processes, including hypoxia, and this stimulates ER stress. And it's a bit like, instead of the black box, we've got the yellow circle now. Something happens here, and you get inflammation. But inflammation is certainly triggered with the hypertrophied cell, and the fat cells themselves, the adipocytes, start to release pro-inflammatory cytokines. And this is just some of them. It's not an exhaustive list, but a key one is MCP1, and this attracts a certain form of macrophage, M1 macrophages, that are activated, and these release cytokines that kind of promote the inflammatory response, and you get a vicious circle here. But there are other problems that arise. There's increased circulating fatty acids, and the fat cells start to release less adiponectin. There are other adipokines I'm not going to mention, but adiponectin is a key one. And so these all contribute to the insulin-resistant state. And this is thought, I'll just summarize the key points. So obesity, hypertrophied fat cells, inflammation. One of the key plays is TNF-alpha, and TNF-alpha decreases insulin signaling, and I'll say a little bit more about that in a moment, but it affects insulin action directly. The decreased adiponectin also has consequences, because adiponectin, if you get low adiponectin levels, you get a decreased activation of AMPK, and increased fatty acids also have an effect. So let's take each of those in turn. Inflammation, TNF-alpha, it's been shown that TNF-alpha combines with its receptor and it blocks the function of IRS1. So it has a direct impact on the insulin signaling pathway. If you block insulin signaling, you have a detrimental effect on glucose uptake and glycogen synthesis. So that's fairly straightforward, okay? And that's been shown in animal models. I'll say a little bit more about the human experience at the end. Adiponectin, AMPK, this is supposed to be a muscle cell. AMPK is a critical regulator of energy metabolism in skeletal muscle. So if you exercise, you go for a run, you activate AMPK, and this increases glucose uptake and lipid oxidation. It improves metabolism and provides energy for the exercising muscle. Metformin, interestingly, also activates AMPK, predominantly at the liver, but it also has effects in muscle and has the same consequence. And adiponectin does the same and activates AMPK. So if in obesity you have low adiponectin levels, you're going to have reduced activation of AMPK and reduced activation of glucose uptake and lipid oxidation. And then we have the increased fatty acid levels. We've known for years, since Randall developed his Randall cycle around fatty acids and glucose uptake, but it's more sophisticated than that. And if fatty acids are good, I mean, as we know, they're a good source of energy, but so long as you can oxidize them, and the mitochondria are the main place for beta oxidation. But any excess fat will be stored in the tissues, and this can occur in muscle. You can store intramuscular fat. But if this becomes saturated, then you get spillover and the production of toxic fats, such as ceramide and diacylglycerol. And ceramide has a direct effect on insulin action through the signaling pathway and causes insulin resistance. And DAG, or diacylglycerol, can also have effect through inhibitory serine kinases and insulin resistance. So there's lots of ways obesity can cause insulin resistance, and part of it is through inflammation. So let's just go back to the adipocyte. So this is in the good times when there's a lean subject, this is healthy. There's good macrophages, M2, and IL-10 is an anti-inflammatory agent, so the levels tend to be high and they kind of repress the inflammatory process. But as the fat cells enlarge and become hypertrophied, you get pro-inflammatory cytokines, you get activation of the M1 macrophages, and, you said before, this vicious circle. But there's emerging evidence that it's more complicated than that in the activated M1 macrophages, that other inflammatory cells become involved. So neutrophils are attracted into the adipose tissue, and other B cells and T cells that are normally associated with the adaptive immune response become involved. So the inflammatory process it kind of takes off in the obese tissue. This is work that's in progress, but it was thought just macrophages, but there are other inflammatory cells, and these contribute to the inflammatory process. So that's happening in fat, but we know that there's crosstalk between tissues. And so as the fat cells become hypertrophied with the inflammation, you get spillover of TNF-alpha into the circulation, other inflammatory molecules, you get fatty acids and low adiponectin, and these have effects on both muscle and on liver. So you can see how a process that starts off in fat can spill over and start to affect the function of other tissues, contributing to insulin resistance across the different tissue sites. As I said before, muscle is the key peripheral one and liver is the central one. So it gives a systemic insulin resistance. But what is always refreshing is that life's not as simple as we would hope it would be. And there's some evidence now that there's a variability in the obesity phenotype. So it's recognized that many people have obesity and are called metabolically unhealthy. So this is what we understand as the bad obesity, that they have features of the metabolic syndrome. As I mentioned, they develop the pro-inflammatory state, and this affects the majority of obese patients. But it's increasingly recognized that there are some people who become obese, but they don't develop the adverse metabolic features, and hand in hand with that, they do not develop the inflammatory process. It's a good form of obesity. It affects a smaller proportion of the obese population, but what we need to understand is why is it that these people can put on weight and store fat but don't get the adverse consequences of both metabolic and inflammatory. Because when we think about it, there's not a problem with the adipose tissue is there for a function, it's to store fat. And clearly we want to store fat for lean times. And it seems that these individuals they may be more advanced, I don't know, but they're able to store fat without the adverse consequences. I'm stuck again. Oh. So what about, we've got this association with obesity, inflammation and insulin resistance. What happens if you improve the obesity? And a good way of doing this is through bariatric surgery. So this is a study, quite a nice study, was published in JCI in 2012, where they looked at gastric banding and they looked at gastric bypass. And they looked at before and after the procedure in each case. And you can see that this is the body weight, they're obese. Before and after, both groups lost around 24 kilograms in weight. So quite a substantial weight loss. In line with this, they got an improvement in adiponectin, so adiponectin levels rose in each group, and C-reactive protein as a marker of general inflammation went down. So this is good. So as you lose weight, both the insulin, so the metabolic features and the inflammatory features appear to improve. And they then did clamp studies just to confirm this. So this is the banding, the bypass, and they did a clamp. So if you just look at the black bars, which is the insulin-stimulated glucose uptake, predominantly into muscle, this is before the procedure, it's down, they're insulin resistant, it improves. And we know this, insulin resistance improves with bariatric surgery. What they then did, which was particularly neat, if you just look at the bottom figure here, they looked at the inflammation in fat. They took fat biopsies, and again, this is before and after surgery, before and after. So IL-6, an inflammatory cytokine, went down, TNF-alpha went down, and the good guy, IL-10, went up. So surgery improves the metabolic features and improves the inflammatory process. What we can't dissect out from this is whether actually weight loss improves the inflammation and as a consequence improves the insulin resistance. I don't think it's as simple as that. I think the two are linked together though. But I think this is a slight sideshow because I think we can get too hung up about general obesity and miss another important group, which actually may be more important to your ethnic group in terms of fat distribution. And this is a slide from Steve O'Reilly, a patient of his, who presented with severe insulin resistance. And it doesn't show very well here, but she had a lot of fat centrally, particularly under the neck, visceral fat. And as he describes, there's no buttock fat, no bottom. And if you look carefully at her limbs, they are very muscular. Oh, there we go. So that's her forearm, and there's no fat there at all. And if you do a pinch test, you can't pinch any fat. So this lady has got a problem it's not general obesity, the fact that she's got very little peripheral fat, so she has a problem of altered fat distribution. She has decreased subcutaneous fat, and as a consequence, she tends to put the fat into the visceral tissues and into ectopic tissues such as muscle and liver. And the problem is if you have too much fat in these tissues and you can't metabolize it, then you get insulin resistance. But there is a paradox here, as many of you will be aware, that insulin-resistant type 2 diabetic patients have a large amount of intramuscular fat. But if you do a lot of exercise, so the athletes who will be running at the Commonwealth Games in a few weeks' time, many of them will have the same level of intramuscular fat. The difference between these groups is that these guys, these subjects can metabolize it, they've got good mitochondria, they can oxidize it. These patients can't. So I'll just move on from that. That was just to make the same point. So the summary so far: inflammation is a feature in most but not all obese individuals. Decreased obesity through surgery improves insulin resistance and inflammation, and ectopic fat distribution is also associated with severe insulin resistance. Moving on to muscle. One of the other paradoxes, and this is work done by a Danish group and Professor Pedersen in Copenhagen, is that muscle itself releases cytokines. And if you look at this graph here, this is taken from one of her reviews. This is the profile of cytokines during sepsis. An insulin-resistant state, TNF-alpha rises, IL-6 goes very high, and there are other cytokines as well. Almost exactly the same picture when we exercise, an insulin-sensitive state. The only difference is you don't get much, if any, rise in TNF-alpha, but IL-6 goes up. So why is that? You want to be insulin-sensitive, not insulin-resistant during exercise. But it appears that muscle itself releases IL-6 when we exercise, and that's the source of this peak. And IL-6, under certain circumstances, can improve glucose metabolism and fat metabolism. So that's confusing. I'm telling you at one stage that pro-inflammatory cytokines can cause insulin resistance, but actually if you exercise the same fellas, the same cytokines, IL-6, can improve glucose uptake. And so this moves me on to some of our own work that we've been doing in Newcastle, where we take muscle biopsies from subjects, and we can take a needle muscle biopsy from the skeletal muscle, and we can grow the muscle cells in the lab. We can grow them from mononuclear myoblasts to myotubes that fuse, and if you leave them long enough, they start twitching in the lab. And what we did was we took muscle cells from subjects that we knew were insulin sensitive control cells. They had no family history of diabetes. And then we went out of our way in the clinic to identify type 2 diabetic patients who are very insulin resistant. These were patients who were on more than 100 units of insulin a day, but they weren't particularly obese. Their average BMI was 31. So it's not as though they were very big people, but they were clinically very insulin resistant. And when we looked at insulin action, shown here in the black bars, in the muscle cells in the lab, there was still insulin resistance in the diabetic versus the controls. So there's something seems to be retained in these muscle cells that would suggest it's either a genetic or epigenetic phenomenon. Now, how this links to inflammation, when I started doing this work, I wasn't interested in inflammation at all. It was something that the immunologists did. But what took us to this area was that the same control and diabetic muscle cells, we knew there's a difference in insulin action. We didn't want to go up and down the insulin signaling pathway because people had done it before and found no abnormality. So we looked at gene expression between the controls and the diabetics in these myotubes. And this is a heat map. It's an example. It's just a section. But where it's red, it's overexpressed compared to the other groups. So here, in this quadrant, these genes are overexpressed in the controls relative to the diabetes. So you might say, well, that's an interesting, because they're deficient, the diabetes. We always think of deficiency being the problem in disease, and it might well be. But we were particularly interested in this group because these were genes that were overexpressed in the diabetic muscle cells that are insulin resistant. And we were interested because when we looked down this list, they were all inflammatory genes, or genes involved in the inflammatory process. So what we'd used gene set analysis to look at these genes, and we got a cluster of pro-inflammatory genes, and we found that using ingenuity analysis that a key regulator was P38 MAP kinase. So what does that do? Well, it does a number of things. But one of the things it does is elicit an inflammatory response. So as P38 MAP kinase becomes phosphorylated, it's activated, and it produces this immune response. And it's quite a ubiquitous immune response, including some of the cytokines that we'd found overexpressed in the diabetic muscle. So we got quite excited by this. And there we go. So we asked the question, well, is P38 MAP kinase actually overactivated in our diabetic muscle cells? And the answer is yes. This is a reference. So we looked at phosphorylation of P38 MAP kinase. This is the controls here. Diabetics here. These are a representative block, but this is the result from all of our diabetics and controls. And you can see it's activated in controls in the basal state and after insulin, but it's much highly activated in the diabetic sample. So we got really excited then and said, well, what happens if you inhibit the activation of P38 MAP kinase in the diabetic muscle cells? And the first thing we found is that the inflammatory response, as you predict, is suppressed. So you can see here IL-6 expression goes down, IL-8, which is a particularly nasty and active interleukin, that went right down, MCP1. MX1 went down but not significant, and the other one went down as well. So this was, again, encouraging. There seemed to be a coordinated decrease. So we looked at glucose uptake. Here's the small response in the controls in the diabetics. With the inhibitor, no response. So that was a bit disappointing. We've shown that P38 MAP kinase is activated, pro-inflammation in the muscle cells, but inhibiting it, blocking the inflammation, did not improve insulin action in muscle. And something similar has been found in an animal study looking at the NF-kappa beta pathway, and this is the more traditional pathway of inflammatory activation. So let me just talk you, this is a very kind of a noddy guide to the pathway, but here we have cytokine, the activation of the pathway activates IKK2, and this phosphorylates IK beta on the complex of NF-kappa beta, and phosphorylation leads to this, the split of this, it comes away, this becomes activated, and you get the inflammatory response. And there's a very neat study that I'll show you the results of, where they said, okay, if this pathway is all involved in inflammation, if we knock out this step, so if we ablate this gene in muscle, then we'll block the inflammatory process, and we can ask the question, just as we had done, does it improve insulin action? And not sure. Am I pressing the wrong button? Oh, there we go. So this is the, it may be because of the number of slides, I don't know. But this is the result that they found so this is the representative blot, and these are the figures here. So this is a mouse model, but this is the wild type, lean, healthy, and this is a measure of insulin phosphorylation or insulin action at the insulin receptor. So this, they got a good response. As we know, if you make the animals obese, insulin action goes down. This is the wild type. So that's a normal response. This is the group here. Well, this is where they knocked out in muscle this particular pathway. They knocked out the inflammatory response, but there still is insulin resistance. So knocking out the inflammatory process did not improve insulin resistance in these animals. Very similar to what we found in the other pathway in muscle. So to summarize this bit, what we can say is that skeletal muscle is the key peripheral site of insulin resistance in type 2 diabetes, that skeletal muscle does release pro-inflammatory cytokines. Some of those are increased during exercise, but there are other ones that are released, including MCP1, IL-8. But these local cytokines do not appear to contribute to the insulin resistance in muscle. So they don't, although they are released locally, they're not contributing to the insulin resistance. This is work in progress, and we need to, am I over time? It says I've got 13 minutes here, which seems a bit surprising.
13 minutes.
13? Yeah, okay. Is that okay? Okay, I'll be quiet in a minute. I'm coming to the last bit. So what we think happens is that obesity and the inflammation here can contribute to insulin resistance by crosstalk, but the inflammation in the muscle itself is not a key player. So, have I gone backwards? There we go. Right, so the last bit. So implications for clinical practice. Should we be blocking the inflammatory process in obese patients? That's the question, like an essay question. So here we are. So this is a representative sample of some of the studies that have been done. So this is a group this is a Danish group where they looked at interleukin-1 and they blocked the receptor using a monoclonal antibody, and they gave the therapy in type 2 diabetics. This is a baseline, and after 52 weeks treatment, this is control in white, black is the treatment arm. And so you can see, if we just look down, start at the bottom and work up. So here, this is the C-reactive protein, this is IL-6. With treatment, both improved, both came down as improving the inflammatory process. So that's good, that's a good start. Pro-insulin ratio, they used to say that it's a marker of beta cell function. That improved a little bit after 52 weeks of expensive treatment. But hemoglobin A1C, no effect, not a sausage. So this is not doing anything for our diabetic patients. They didn't look at insulin resistance in this group. What about anti-IL-6? And somewhat surprisingly, not much work has been done. I couldn't find much reported on this, but this was a study where they looked at anti-IL-6 therapy in arthritis. Now, the patients with arthritis, some of them had type 2 diabetes. So what they did is, while they were treating for the arthritis, they looked at the hemoglobin A1C, which is along the y-axis here, and looked at it before 1 month and 6 months after treatment. And this is really impressive. So you get an improvement after a month and 6 months. But this is what kind of irritates me. It wasn't a placebo-controlled trial. They didn't run a control arm. And as you will well appreciate, if your arthritis starts to improve, you start to feel better generally, you'll become more mobile, other factors improve that could also improve your mobility and your insulin resistance, and you have an impact on your diabetes control. So while that looks encouraging, we've got to take it with a pinch of salt. Whoops. So I've missed no, one of my slides has disappeared. So anyway, no, that's fine. And so IL-6, maybe, we need a proper trial. Anti-TNF alpha, well, the treatment for this has been around a long time. And in fact, Roy Taylor, one of my colleagues in Newcastle, did a study on this at the very beginning. So they asked the question, does anti-TNF alpha therapy in obese patients with type 2 diabetes, does it improve insulin resistance? And they treated, it was a single infusion in 10 patients, anti-TNF, and 11 with placebo. So it's a small study, 6 weeks after a single injection, and they measured insulin sensitivity using an insulin tolerance test. I don't think Roy would use that these days. You'd prefer to use a clamp. But the point was that at pre-infusion, the measure of insulin sensitivity, to give you a guidance, is that the higher the value, the more insulin sensitive. So this is the comparable at baseline. And actually, there's no difference after 1 week, and it's not significant. There's a trend of a difference, but it looks as though the placebo had a better effect. So the bottom line here is that anti-TNF alpha did not improve insulin resistance in type 2 diabetes in this study. And a subsequent study using etanercept, again, anti-TNF alpha, a bigger study, 56 patients, they had the metabolic syndrome, so there'd be insulin resistance with dyslipidemia, with hypertension, the classical features of the metabolic syndrome. They did a nice study, they randomized to placebo, etanercept, and with etanercept they got an improvement in the inflammatory markers, C-reactive protein. Adiponectin showed a small increase, it was significant, it increased a little bit. Interleukin-6, that went down. With the treatment. So that's all looking good, but when they looked at insulin resistance, no effect. Okay? So no benefit, and no benefit on blood lipids. Oops. So I think the problem here is that if we go back to my original slide, we're saying that there's an activation in the inflammatory process, and there's a whole cascade of cytokines. And it probably is illogical to try to pick off individual ones. So I've shown you data of TNF alpha, IL-1, IL-6, because you're only taking away part of the inflammatory process. And one of the better ways systemically would be to try to block the inflammatory process at a more proximal site, just as we try with P38 MAP kinase inhibitors and the knockout in NF-kappa beta. But those, remember, were in muscle. They were just in muscle. So what? Can you do it in whole man? And the answer is yes. And this is back. You've seen this pathway, the NF-kappa beta pathway. You get activation of NF-kappa beta, and you get all these cytokines. So instead of trying to pick off these individually, can you block it upstream? And the answer is yes. And there's a very sophisticated, very modern agent called salicylate, which will do this. So this is related to aspirin, acetylsalicylate being the aspirin, but this is salicylate, and aspirin will have the same effect. It's got more side effects. But so you could do this. You can block the inflammatory process. And coming to the end now, this is a nice study that was done with salicylate therapy in type 2 diabetes, published last year, midsummer. And the black dots and the solid line are the salicylate group, and the dotted lines are the placebo. So hemoglobin A1C, this is the placebo. Within a matter of weeks, 8 weeks, hemoglobin A1C had come down and remained down. Now, okay, you're probably looking at the scaling, you should be, because it's about 0.3% improvement. So it's not a cure for diabetes, that's for sure. But actually, it's comparable to some of our oral hypoglycemic agents. So it's not bad. And certainly as a proof of concept, it's a reasonable response. It's interesting, they got more hypos in the salicylate group. Fasting plasma glucose improved. And in the next slide, what was interesting, that some of the inflammatory markers improved. So we have the neutrophil count. It's a bit odd here that they got crossover, but the neutrophil count went down. Adiponectin levels went quite high actually in response to salicylate. So this is quite encouraging, and it gives us a kind of a pointer, a signpost as to where maybe we should be going in the future, is to look at the proximal steps of inflammation and trying to target these. The trouble is, obviously, is that you're thinking, well, if you kind of have a blunderbuss effect, you might then increase the risk to infection and where you need the inflammatory response. So there's a bit of balance here, but it seems that the more sophisticated monoclonals, the targeted, on the evidence so far, is not producing the goods or the benefits in type 2 diabetes. So this is my last slide. This is my overall summary. That inflammation is a feature of obesity and type 2 diabetes. Sorry, it's my last but one slide. Inflammation is a feature of obesity and type 2 diabetes. Skeletal muscle releases pro-inflammatory cytokines, but there's no evidence to date that they contribute to local insulin resistance. Blocking individual cytokines at a systemic level appears not to improve insulin resistance and diabetes, and I've shown you some of the slides that support that. Blocking the inflammatory at the cascade at a more proximal step may be of more therapeutic sense. And my last slide, I just want to acknowledge my group who've done the muscle work, headed by Audrey Brown, and other colleagues in Denmark who've helped with this, and these are the people who've sponsored our work. So I'd like to thank you for your attention.
Thank you, Dr. Mark, for the excellent talk on this topic, inflammation, insulin resistance, and type 2 diabetes, where he has clearly elucidated the link between obesity and inflammation, skeletal muscle and inflammation, and of course, not only that, the implications of these inflammatory markers in clinical practice. So now we have time for a couple of questions from the floor.
Sir?
Yes.
Can I?
Yes.
I will ask.
Yeah.
Okay. Sir, there are two different pathways. One is a MAP kinase pathway and is IRS pathway. And there is a difference between MAP kinase and IRS that produces all the ill effects of your insulin resistance. And expression of all this insulin resistance is by the MAP kinase pathway. And is it wise to go and block the MAP kinase pathway instead of going and blocking the higher level?
Yeah, so that's a very good point, because P38 MAP kinase, there's some evidence that it involves in glucose metabolism directly. We essentially followed the route that we were taken through the increased inflammation. I think your concern would have been relevant if we'd shown an improvement in insulin action and thought, well, we better give this blocker to patients. But because there was no effect on glucose uptake, we didn't go as far as that. But I think you're right, it is complicated. I think it just shows our ignorance in terms of the interaction between inflammation and metabolism, and that some of these pathways have dual or triple functions, and that under circumstances or triggers, they will affect different outcomes. So it is a very good point, that.
Mark, thanks for a great talk. I have one question, and that is Barbara Koke, who is the ADA president, has this hypothesis and somewhat gathering speed that hyperinsulinemia precedes insulin resistance. But the interesting data is that insulin resistance is probably protective in certain tissues. So have we got it wrong, and are we barking the wrong tree?
Yeah, so that's a good point, and certainly that comes back to the feed and fast hypothesis, where in years ago when we used to have times of fasting, it probably was of advantage to be insulin resistant. I'm not sure in the present age it is a good reason and a good outcome. I'm just thinking that insulin resistance will produce higher insulin levels, and you might say, well, that's good because it protects the beta cell, but there's signaling effects at the beta cell itself. So that is an idea and a hypothesis, but I think in this day and age, it may not be such an advantage.
Prasad from Chennai. Thanks, Mark, again for the wonderful talk. A couple of things. One is in the salicylate group in the study, was there any change in the weight, or would there be any role of salicylates in weight management?
Sorry, which study was that?
In the study you showed where the salicylate.
The salicylate study. Yeah, I'm not sure. It's a good point.
Mark,
Because
can
you're
I-
right, you're absolutely right. I don't think there's a profound change in weight that would account for all the metabolic and inflammatory improvement, but I can't remember the changes in weight.
Mark, can I supplement because I'm aware of the study? Krishna here.
Where is it?
Alison Goldfein, who did this, I'm here.
You've got it there, have you?
Yeah, I got it. There was no change in the weight in the study. There was that was statistically significant, and Alison's actually redoing this study in a larger population. So we should probably get more data. And one of the things that she's planning is to do it in patients with PCOS.
Okay. And that'd be interesting. So, so thank you. In fact, I'm going to refer all my questions now to Krishna.
Mark, see, the molecular biology of insulin resistance is always more than exciting. But the riddle is in the form of treatment.
Yeah.
So when it comes, when you approach, whether it's inflammation or whatever, see, we come to know about PPAR or incretins or SGL2. So how do we, strike the bullseye? Okay, do you think that ideally we'll have a candidate, maybe some gene, some kinase activation to target on the insulin resistance?
Yeah, well, so that's what a lot of people have spent years and years trying to address. And there's no doubt that insulin resistance, if the response to insulin is impaired in type 2 diabetes, and often precedes, it's a feature of siblings and offspring of type 2 diabetes, those at increased risk. So I think there is a genuine problem there. There are some people who say it's nothing to do with the muscle or the cascade, but it may be all due to obesity, to the ectopic fat. And that certainly is a feature. I think we'll only dissect this out by being able to systematically treat and improve these factors and see if we normalize insulin resistance completely. But I think the other point that we forget is insulin resistance is a fluid. It changes with time. So I suspect I've not done much exercise while I've been here, busy. My level of insulin resistance will have gone up. And so it does fluctuate with time within certain limits. So, but to answer your question, I don't think there's going to be a bullseye. I don't think there's a bullseye. I'd like to be proven wrong, but I think from all that work that's been in the insulin signaling, there's nothing that's kind of popped up as the target.
Just little, the MAP kinase, why is that we are not able to achieve a lot with the with metformin? Ultimately, I don't know whether it fails, we are not able to control with metformin alone. So what is the drawback? MAP,
I think the concern, well, it didn't have an effect. I mean, they have given it for other treatments, but it's, I think the concern is that you can affect a number of different pathways. There's obviously pathways in terms of regulating cell cycle and differentiation, and you then become concerned about the effect on cellular function and turnover.
Maybe next time come back with an answer or take more of our younger generation. I always complain with Alberti that you don't train us in basic science. So we will be able to come and work with you and solve the riddle, okay?
Okay.
Dr. Mark,
Yeah.
I would be interested to know what would be the consequence with regard to the inflammatory markers if someone is advised to exercise, into extreme forms. So have you got any idea about it?
Yeah, that's a very good point. So I don't know what happens to you. I think there is a slight attenuation with regular exercise. But certainly IL-6, if you do bouts of exercise on a regular basis, your IL-6 and the other cytokines will go up.
Right.
So, but I think your question is what happens over a period of training. I don't know what the answer is there. I don't think you lose it.
Dr. Mark, it was a fascinating lecture. In continuation of this question, can you comment on the beneficial effects of exercise? Because recently, at least in rodents, it has been described that there is a molecule called irisin, which is released by skeletal muscle.
Yes.
In response to exercise, which is through the PGC1 alpha activation pathway. And irisin has a property of converting white adipose tissue to more metabolically active, what is called bright adipose tissue, where
Yes.
ECP1 is activated.
Yes.
So maybe this is counteracting the inflammatory mediators and improving the insulin sensitivity?
It may well do. That's a very good point. And I think that I think we are stuck with the paradox still that, well, we know that exercise, I think we're all on the same page if we say that exercise is good for us. I think, my father-in-law disagrees, but he's 90 and he's never exercised in his life, so maybe he's right. But I think generally we agree that exercise is good for us. And I think that I'm a bit wary about the irisin story. I think there are some question marks over that about replication and those factors. But yes, I think we've got to, just as there was a lot of excitement around adipocytes being endocrine tissues releasing adipokines, I think the same is happening now with muscle. And I think IL-6 is of interest, but irisin and its role in terms of beta cell and crosstalk, I think that's the other thing we're seeing here, this interaction between tissues and their influence. And it would make sense that they're able to talk to each other and respond in a coordinated fashion to metabolic or environmental change.
Sir,
So last question.
so to address the insulin resistance in the fat, there is only one molecule, pioglitazone. Is there any other molecule in the pipeline where it can come into the market in the phase 3 trial?
Yeah, not that I'm, so yes, you talked about the glitazones.
Yeah, because there is only one molecule available in
Yes,
the
yeah, yeah,
armamentarium
yeah. Yeah, so you're
to
asking if
address
there's
the insulin resistance at the fat level.
Yes.
In the liver level, we have got metformin with
Yes.
a small spillover on the fat,
Yeah,
and vice versa.
So that's a very good question. So are there any emerging treatments or targets? I'm not closely involved with what's happening with the pharmaceutical industry and what they develop, but I have heard, now it was very exciting a year ago, and it was published, I think last summer, that a ligand for the adiponectin receptor. So this was Kadawaki, who published in Nature, and they've got a molecule that activates the adiponectin receptor. Now that's very exciting because they've had real problems. They've not been able to generate the whole adiponectin molecule, which is a very complex molecule. But my understanding is they've got this ligand, they've published data, it has effects on insulin action and other beneficial effects on lipid oxidation. So I think this is looking at specific elements of what's wrong in the pathway, and low adiponectin levels I think is a real concern. So being able to replace that would be an advantage. So that's an example of what I think is coming on the horizon.
I think with this we end the session, and we thank Mark for a wonderful lecture and the
Thank you very much. Thank you.
interaction we developed. Thank you.